Dr. Faisal sir. Ma'am.
Thank you. Thank you.
Thank you.
Thank you so much.
I think it is stuck.
Graduation and post-graduation from Raja Mutaya Dental College, Annamalai University. Sir is a member Board of Studies of the Kannur University. Sir is a PhD guide of the KUHAS University. Sir is the clinical director for Special Olympics for the Kerala State. Sir has more than 100 publications in international and index journals. Sir was also awarded the Fellow of ISPPD in the year 2021. And Sir has also received the IDA National Award for the Best State CDE Chairman 2022. On behalf of the organizing committee, I would like to welcome you, sir.
Thank you very much. Thanks a lot.
I would like to also introduce the other moderator for the session, Dr. Gunjan Yadav, ma'am. Ma'am is currently working as a professor and head in the Department of Pediatric and Preventive Dentistry, Sardar Patel Postgraduate Institute of Dental and Medical Sciences, Lucknow. Ma'am is a competent academician, clinician who graduated and attained her master's in dental surgery and periodontics in the year 2007 from Subarti Dental College, Meerut. Ma'am was also awarded distinction in human anatomy. Ma'am is also an executive committee member of the ISPPD and also for IDA Lucknow branch. Ma'am has a teaching experience of more than 17 years in both UG and PG, along with immense clinical experience, and exhibits keen interest in saving the deciduous teeth. Many research projects have been completed under ma'am's guidance. Ma'am has many national and international publications and is also working as a reviewer for many renowned journals. Ma'am has also been an organizing member in many conferences and CDE programs. Ma'am has recently secured the prestigious ICMR project grant of 50,000 rupees for the short-term scholarship project guided by her for the session 2023-24. A warm welcome to you, ma'am.
Thank you so much. Thank you so much. Thank you and to Madhu sir and ISPPD.
Now, I would like to ask Dr. Faisal CP sir to introduce the first speaker for the session, Dr. Nitesh Tewari sir.
Hello, good afternoon to all of you. I'm very happy to introduce my good friend, Dr. Nitesh Tewari. He's a very active member of ISPPD, who has a lot of interest in dental traumatology, clinical care, and research, and evidence-based medicine. He has over 183 published publications and 7 textbook contributions. These include 45 systematic reviews published in highly ranked journals in the past 4 years. He has lectured in over 170 events across several states in India and in 19 countries. He has conducted dental traumatology and EBM workshops for postgraduate students, PhD scholars, and medical dental faculty in India, Nepal, United States, Japan, Brazil, and UK. His works has been awarded by International Association of Dental Traumatology, International Association of Pediatric Dentistry, Craniofacial Research Foundation, International Association of Dental Research, Japan Dental Association, International Federation of Endodontic Associations, Royal College of Surgeons of Glasgow, and several other organizations. He is a fellow of 6 societies and presently serves as a communication officer of the International Association of Dental Traumatology and General Secretary of the Indian Society of Dental Traumatology and Secretary of the Evidence-Based Dentistry Network of IADR, and he works as the additional professor in Department of Pediatric Dentistry at All India Institute of Medical Sciences, New Delhi, India. We welcome you to this virtual PediaRare 6th session, and over to you, Dr. Nitesh, for your lecture.
Thank you, sir. Thank you very much.
Thank you, sir. Now I request Mr. Dev to display the presentation.
We talk about crown and crown root fractures as a part of this program, the PediaRare. It's a great initiative on part of the society, and it's the 6th version. That means a lot because that's an opportunity for you to learn everything together. And I'm so honored to be part of this program. Thank you to the organizers for the kind invitation. So when you talk about crown and crown root fractures, and in fact the dental traumatology, the first thing or the thing which makes you worry about is dental pulp. And dental pulp is a connective tissue. We all know that. We have been reading about it since our BDS first year. And the dental pulp per se is the whole sole criteria for you to manage a lot of things, and not just traumatology. And today, when we talk about crown and crown root fractures, it's really important for us to understand certain factors or the certain ways through which the pulp gets exposed, and why it's so crucial for us to have an adequate management. We all have seen cases like this, and sometimes people are lucky, or the teeth are lucky, that they report to us as pediatric dentists in this state, because you can see the healthy pulp, you can see the living tissue. However, there are situations where the people are a little less aware, where the access to the healthcare is not there, and ultimately they end up with certain complications. And apart from that, there can be bodily injuries, there can be combination traumas, and which complicate the entire scenario of pulp management. And you find that in all sort of scenarios. And if you talk about how dental trauma approaches to the pediatric dentist in India, no matter where you are sitting in this country, you find delayed complications or the trauma which are reported with a delay of few days to months or to years. And that's a common reality. We did a postgraduate research on delayed complications, and in that, the mean delay has been reported as 2.5 years. So that's the level of delay which is being reported at a tertiary care center like AIIMS New Delhi. And this is how we usually see the patients. We are not seeing the immediate traumas. And one of the reasons why we see the delayed complication is lack of awareness. People are not aware. And the second is that the general apathy about the dental problems or the dental injuries is also one of the main concerns. And when you look into the radiographs, a lot of things go wrong, and that's what we will be focusing, that how to prevent those problems, especially in crown and crown root fractures. And since it's a more of an academic lecture, so I would like to make sure that you are aware of certain classifications. I'm not going into the details of Ellis classification, Andreassen's classification, WHO. You all know that. And when you are writing your papers, you should be in complete command of at least 5 to 6 classifications, especially Rabinovich, Pulvers, Andreassen's, WHO, Ellis and Davy. And only Ellis and Davy should not be the criteria, no matter which part of the country you are. You should be focusing on at least Andreassen's classification. This is the most recent classification. If you are not aware, you can download this article. This is NA0D classification, and I think Dr. Kavitha is also talking about it because we had a conversation regarding it. So this is a classification which is partly based upon Andreassen's classification, and it's more on ICD-11 platform, and it's a big achievement for dental traumatology because we now have a classification which is well established and it's ready to use. Another thing new as a postgraduate or a young faculty, when you are looking at dental trauma cases, you should always understand that when an injury occurs and it leads to crown fractures, there's a great chance that it will lead to some problem in periodontal ligament as well. And what do we call them? We call them combination injuries. And Eden-Bissell Dental Trauma Index or Dental Trauma Severity Index, you should read about it. So it deals with the multiple type of injuries in one tooth. So if you just look into the slide, it's a 5-digit system. The first digit talks about the FDI nomenclature. The second digit talk about any form of crown fractures. The third digit talks about the third column or the second digit talks about the root fractures. The fourth column talks about luxation injuries in capital letters. And then fifth column talks about root maturity, and the sixth column talks about the bone, or the fifth digit is the bone, which will be represented by plus and minus. So if you look into how the system goes, so you have FDI nomenclature, easy, you can do it. Then comes the crown fractures, much easier, you can easily do it. You know enamel fractures, you know how you diagnose enamel dentine pulp, and you have numerical system for that, 0, 1, 2, 3, just write that number. Then you have root fractures at 3 levels, like cervical, middle, and then apical third. You fix that up, 0, 1, 2, 3. And then comes the luxation injury. Only the first letter has to be used, like none, concussion, subluxation, extrusive luxation, lateral luxation, intrusive luxation, avulsion. So that's again one part really easily done. immature, mature, and resolved, which is only for the primary teeth. And then the fifth digit, which is for the bone fractures, you have bone fracture present and absent. So it's either plus or minus. So that's what Eden and Faisal envisaged to formulate as a severity index, and it's a well-established index which is being used by multiple research authorities, especially Dental Trauma Guide. And that was modified when soft tissue injuries were added as a part of feedback group, and that is written as a superscript. So if I have to write that entire classification for an injury, I will just show you quickly. So it is like that you need to write everything together, and when you have to mention that as a superscript, the soft tissue injuries go at the end. So those of you who do not know it, please read it, because this might come to you as maybe a short note or maybe as a viva voce if your examiner is interested in trauma. So it's something which you should not be totally unaware of. So that's one of the take in terms of classifications when it comes to crown and crown root fractures. You can have crown root fractures with luxation injuries, and that's where the Eden-Faisal index comes handy. If you talk about idiopathogenesis, so we gave this pathognomic pentat for TDI some time back, and this pathognomic pentat primarily talks about the different types of mechanisms of injury, the predisposing factors, elements, demographic factors, intent. And if you look into what are the factors which are directly in our control, what do you think are in control? So the most important thing which is in control is the predisposing factors. And I have a brief slide for that. So if you talk about crown root fractures, the first and foremost, the causative factor is the overjet, is the proclination of the teeth. So if you look at this child and you look at you have been looking at trauma patients since past 1.5 or 2 years of your post-graduation. And if you look into, if you think about any trauma patients, invariably that patient has got a malocclusion. And if you talk about evidence-based orthodontics, and the biggest name in that field is Martin Coburn from UK, and in his one of the most cited papers, he wrote that one of the only ways to prevent trauma is to treat the malocclusion or intercept the malocclusion, and he's partly right, because if you correct the habits, if you correct the myofunction, ultimately you correct the malocclusion, and there is a cushion of lip, there is a cushion which is behind the teeth, which is in the form of the tongue or the lingual musculature, and the chances of trauma are reduced. So if you look into the entire process, this is all leading to the higher susceptibility or predisposition of a patient or your patient to dental trauma. So once the dental trauma has occurred and it has resulted in a crown fracture, so what are the crucial setbacks? Because we are worried about, and that's what we will be talking or will be seeing or in the treatment paradigms as per IIDT guidelines. So the major setbacks, if you talk one by one, are number one, the severity of the dental injury, the repeat trauma, the sources of inflammation, the minutes elapsed, the time elapsed after the trauma, the age of the patient, and the immune status. So everything together is to be considered when you are looking at the survival. And we did this paper on non-surgical endodontic management of large periapical lesions of traumatic dental injuries sometime back last year. So when we did that, we gave a diagram which is known as continuum of trauma outcomes. So if you look into how crown fractures progress into a non-vital or maybe a periapical lesion, so first thing which happens is an injury. And that injury can be a direct exposure of the pulp. So that is a modus or maybe a nidus for a bacteria to go inside. There will be certain amount of hypoxia because of the crushing injury, which is there right at the pulp chamber, which has been breached. Then there is an additional element of severance of periodontal ligament. And that combination leads to hypoxia of the entire neurovasculature inside the pulp. And that leads to ischemia, that leads to tissue crushing, and that ultimately leads to necrosis. And that is the whole continuum you should be always considering whenever you are looking at a patient. Because sometimes when you look at patients, like I said, we look at only crown fractures because luxation injury has healed or sort of healed. The patient didn't come to us. So we report it as a crown fracture. On the contrary, it might be a combination of a luxation and a crown fracture, and we are now looking only at the crown fracture component. So if you look into microscopic level, you will be finding certain pro-destruction factors or pro-inflammation factors and the pro-healing factors. So there is a balance. So when you do a pulpotomy, you are reducing the chances of pro-destruction factors. You're increasing the chances of the healing, reducing the chances of bad things to happen to the pulp. So if you talk about how do we progress in terms of diagnosis, you need to have a history. So history in terms of dental trauma is always time, the age of the patient, the place where the injury occurred, you all know that, and the medical history. We miss medical history. And if you miss medical history in a hemophiliac patient, and the patient has come with a crown fracture and there is a bleeding coming, and there might be some element of subluxation, it's really difficult. And you should understand that medical history for immunocompromise, for the drugs, and for different scenarios of systemic problems, you should be aware of that. Then the usual protocol of diagnosis, the visual examination, the sensibility testing, mobility testing, percussion testing. So these are all your paradigms or all your arsenal for moving forward when you are talking about the injuries. So when you look into the visual signs, a sign like a necrotic tissue on the top clearly indicates that there is going to be some element of damage to the pulp. I'm not saying that it is a candidate for complete pulpectomy or not, because in the current scenario, in the current literature, we have chances of pulp survival even when you have something like this. So we will talk about it as we move further, or the management protocols. And in terms of investigations, the usual investigations for all cases of crown fractures, especially the enamel dentine fractures, enamel fractures, we have pulp sensibility testing, and mainstay for us in pediatric dentistry department in AIIMS New Delhi, it's the endo eyes or the cold test. We have electric pulp test, and while the pulse oximetry is more of an experimental stage till now. So those of you who are aiming to be innovators, that's one area for you to work. The pulp sensibility testing, if you develop a good one, it will be the best in India or the world with a good global market. So if you talk about the different type of injuries and how we treat them, so uncomplicated crown fractures, the basic one. So injury may be at the level of enamel. Injury may be at the level of enamel and dentine. So if you see the IADT guidelines, and those of you who don't know IADT guidelines, please go and type IADT guideline 2020 in Google. You will be directed to IADT website, and there are 4 papers which are free to download. You can download them and you can save them. It's a really reckoner, especially for your exams. So if you look into enamel infraction, by and large, no treatment, just follow up. And then in cases of follow-ups, you are only looking at clinical signs and symptoms. No radiographs are needed in such cases. Some of the cases where aesthetics are an issue, you might require to do maybe sealing of the cracks. And then comes the uncomplicated crown fractures. So in uncomplicated crown fractures with enamel only, you are looking at the rehabilitation, because it's a permanent tooth and aesthetics is of a prime concern. So you're looking at reestablishing that aesthetics. If your fragment is available, and we will talk about fragment reattachment in next 10 minutes. So when you talk about fragment reattachment, it is with you from this injury till crown root fractures. So that's why we have a separate section for it. And for follow-ups, you don't actually need a lot of radiographs. You just need a follow-up of 6 to 8 weeks, and then it's straightforward after 1 year. However, this is only for isolated cases of crown of the enamel dentine fractures. In the cases where there is some sort of luxation injuries, you require to follow up the patient as per the recommended follow-up for that luxation injury. So that's a treatment scenario for it, and that's why I find it very easy, and I recommend to my postgraduates that if you have guideline, you will be able to learn things pretty easy. So if you talk about enamel and enamel dentine fractures, we are concerned about sealing and fragment reattachment, composite restoration, easy thing, no pulp involved. So that's one of the cases. So fragment reattachment, even at the young age of 6 years. So if you have an enamel small fragment, you can even reattach that fragment, and that solves a lot of issues, and especially it's very, very good for the psychological well-being of the child. So if you talk about the uncomplicated crown fractures, which is enamel and dentine fractures, so here the matter of concern is the remaining dentine thickness. So that you can judge clinically. Sometimes you see the pulp right behind the dentine wall, or sometimes you need to take an X-ray, and which is the mainstay. You require to take an X-ray to rule out any root fractures. And then you need to perform either maybe a liner can be applied, or you can go directly with the either fragment reattachment or you can go with a composite restoration. The composite restoration can be done in the cases after glass ionomer cement restoration, because sometimes when the patient comes to us and we find that the patient is having severe sensitivity, we apply liner, we apply glass ionomer cement, and then in the second sitting, we may do a composite restoration. However, you should always consider fragment reattachment as a treatment of choice if the fragment is available. So it's one of the cases. Liner applied, composite done, aesthetic established, 8-year-old male, and then you can follow up. And in cases even when the there is a root closure, it's even a better case for you, because then you have a complete command, a good sound dentine availability, and then you can perform it. So this particular case I wanted to show, because when you are doing cases in mixed dentition, always try to ensure that the normal anatomy is restored. You should not try to correct the malocclusion. Malocclusion can be corrected later on, and in case the patient does not want orthodontics, there is a lot of time for him to decide on veneering, on smile designing. But right now, your job is only to correct the anatomy, and that should be followed. Sorry. So if you look into the another type of crown fracture, which is a complicated crown fractures, which is enamel dentine and pulp fracture. So here, if you look into it, it's the more severe or the most severe form of crown fractures for IATT in terms of IATT guideline. It's not so in India. I will show you why. So in cases where you have pulp exposures, in that case, the main thing is about diagnosing it properly. So when you have diagnosed it and you know that you are going inside, so gone are the days when maybe liner application or maybe direct pulp capping can be a very good procedure. I am showing a case with it, but by and large, you need to go inside. You need to remove some amount of pulp. That can be a partial pulpotomy, which is known as Sweck's pulpotomy, or you can go even into the deeper pulpotomies. And these days we perform pulpotomies, and there is perform pulpotomies even with a delay of 48 hours, 48 hours, 72 hours. We do that, because you can go deeper and deeper and deeper, and that deeper cut means that you're removing all the necrotic tissue or the possible inflamed tissue, and you are preserving the one which is safe. The another paradigm which is not there in the IADT guideline is the crown fractures or the crown root fractures where the pulp has become non-vital, and we will be touching bases on that as we move further. So you have a scenario, crown fractures, and it reports to us after 4 or 5 years, and then you are supposed to deal with a cystic lesion or a granuloma or a periapical lesion, and along with the crown fractures. So in these cases, there is a separate thought process. So if you have a vital pulp and you know that it's an immature root, so you need to perform apexogenesis. That can be by the pulp capping or by the pulpotomy. The evidence is in favor of pulpotomy, and with calcium silicate cements, which can be biodentine, which can be MTA. This is preferable over calcium hydroxide, and we have evidence for that. While in cases of non-vital pulp and you have an open apex, you have a category where there is an apexification as a possibility, revascularization as a possibility. I'll show you some cases. So direct pulp capping, easy to do here in this case, done with diode laser, 940 nanometer diode lasers, then fragment reattachment performed, things done, easy. While in cases where you have fragments available and then you have a delay, so like in this case, the delay was about 24 hours. So when you have a delay like this, and then you have pulp exposures, and what you need to perform, you need to do is you need to record everything together. You need to take clinical pictures, take the pulp sensibility testing, and formulate a treatment plan. And the hydration of the fragment reattachment, we'll talk about it. Perform the pulpotomy performed, and then etching done, and then the bonding of the fragment done. And if you look into radiograph, it looks like this. So one of the key elements for you when you are doing pulpotomies in the traumatized teeth is that ensure that you are doing sensibility testing of all the adjacent teeth. It's not just one tooth which may have issues later. So you perform pulpotomies, and once fragment reattachment is performed, if you look closely into this radiograph, you will see the mesial and distal margins all approximated. That's one of the best guides to tell that your fragment reattachment has been done well. And at 12 months, if you closely see that there is a dentine bridge formation right there, where the biodentine, where the mineral dioxide aggregate had ended in this case. So that's a follow-up for you for 12 months, and that's how you you go ahead and perform things very successfully. So another case, in case you don't have a fragment, what do you do next? So you need to establish the aesthetics in crown fractures. You need to isolate, you need to have an impression, you need to have a putty index done. And then you can use a blue wax, and then you can create the putty index, do the total etching, and that's a putty index placed, and then the composite restoration done. So in cases where you don't have fragments, it's not that you need to wait and then you need to do a post and core. It's not that. You need to weigh your chances, because it's a young child. You still have a lot of things still in your hand. So if you look into this case, the pulpotopy was performed, and you can see the dentine bridge formation in the post-operative, in the follow-up radiograph. On the contrary, if you look into the non-vital teeth, the teeth which have lost the vitality or have ended up with some necrosis, so there are two major methods, you all know that. One is the mineral trioxide or calcium silicate cement-based apical barrier formation, which is the apexification or apical barrier formation. The other is the revascularization, which is shown here in form of two methods, which is by the blood clot and by any sort of additional agent like PRP or PRF. You can use either of the methods. So because when we did an umbrella review last year, we were trying to look into what is the current level of evidence. Can we select one treatment over the other? We found no difference. Even in the umbrella review, which is a review of systematic reviews, when we are looking at the chances that how can we get some evidence, or can we have a clear superiority of one treatment over the other? Nothing. So in 2025, we don't have any evidence in favor of one treatment modalities. The average success rate is far above 80%. So in all cases, especially when you are using calcium silicate, so you can do both. So how I do it, or how our department does it, we look into the factors like whether the patient is going to come back, going to report back, whether there is any possibility of complication, what is the apical diameter, and we document everything. We document it objectively. We use SWEX criteria for the apical diameter. We use periapical index when we are looking at the periapical reducency, and that's how you should be doing it, because then you are able to control a lot of things. So let's briefly talk about fragment reattachment, because that's part and parcel of your crown fractures, crown root fractures. And this great man, Professor Jens Andreasen, always said that biology should be the basis for your treatment modalities in traumatized teeth, and that's why dental traumatology is little different from endodontics or maybe certain other commercial modalities. But then, because we are looking at human tissues, and we try to hone the human tissues to improve the aesthetics, to improve the function. So in the fragment reattachment cases, the first step is to do the assessment. You classify, use a classification system, see that any pulp exposure is there, or you need to do any pulp procedure. Then you need to evaluate the fragment, just check the fit of that fragment, place the fragment, clean that fragment, because usually patients keep that fragment in dry conditions. Sometimes they are soiled. It's one of the good ways of attaching it to the wax. In case you don't have wax, you can use your applicator tips, because if you have a handle, you have a better control of the 3 dimensions. So that's what's recommended. The step 4 is placement of the fragment back after the pulp procedure or without a pulp procedure, depending on your case. And then final evaluation. So this textbook of traumatic dental injuries for Professor Andreasen, it talks about similar method. It has little differences in terms of cleaning of the fragment by pumice, selective edging rather than total etching, and doing a double chamfer. So what's double chamfer? So when I read this, before that I was already publishing in crown fractures, and I had less faith in any of the pre or post bonding restoration techniques. But then, and I always thought that only the fragment storage and cleaning and maybe hydration is the only thing which is there for us to take care of. But then this book and some discussions with Zafar Sareli and then other co-workers increase the faith, or maybe a desire to look into the evidence again. So why are we looking only at the simple reattachment? And if you talk to 10 pediatric dentists, 8 of them will say that I reattached the fragment and fragment fell off. And it's very common for me to hear it. But the problem is that maybe that we are doing some things wrong. Maybe that the evidence is not correctly judged. So that's why if you talk about the different fragment preparations techniques, first is simple reattachment, where we don't prepare anything. We just place the fragment on the stump and then work is done, like I showed in the picture. Then there are pre-bonding techniques where we do bevels, enamel bevels, internal grooves. Whatever we are doing before the fragment is attached to the tooth. On the contrary, there are certain post-bonding techniques. So the problem with the pre-bonding techniques is that we are compromising on the perfect fit. If the fragment and the stump is fitting like this, after preparation it fits like this. So there is imperfect thing. On the contrary, if you have a post-bonding restoration, you have reattached things. There is perfect fit, and you are doing something on top of it. So we have three main methods: the external chamfer, the over contour, and the vertical groove. We will talk about it one by one. And the reason IADT guideline didn't say anything about post-bonding distortion was this and another systematic review, this one. Both came in 2017-18, and they concluded that there is no evidence in favor of post-bonding or pre-bonding restorations. There is no evidence on that. So we tried to see that were they right, or we tried to see that what were the problems in that systematic review. We saw that one of the papers was from 1995, where the traditional the bonding agent was different. It is not the same bonding agent which is being used. Then there were case series. So that's why we did our own systematic review, and which was published last year. And this paper talks about, and I won't go into details. It says that in uncompleted crown fractures, there is almost double the chances that the fragment will survive, and even in the complicated crown fractures, even better. So that's why we recommended, and when we found the evidence, we tried to see that whether this is actually what's the level of the force required. So we did this study, and it's a very recent paper of ours published in Feb 2025 and accepted in June 2025. And if you look into the four groups, we were talking about simple reattachment, external chamfers, over contouring, and control. And in all cases of post-bonding restorations, the force required to fracture was much better or significantly different from the simple reattachments. So what does it mean? So the systematic review from the clinical study shows that post-bonding is better. And this study gives an indication that there might be some more force required to fracture once you have the post-bonding restorations done. So that's something to ponder about, and I'm very sure that in the next guideline there is going to be certain changes in how the crown fractures are being treated because of these works. So then comes the fragment rehydration. So fragment rehydration, you mean that you need to put the fragment in distilled water or saline for minimum 20 minutes. That's what guideline says. So what we do in this case, we have done certain works. We have done certain works in terms of humidification as a method. We are working on a prototype where a humidification chamber can be used. But for you, in this examination, if somebody asks you that what is the most critical step, it's the rehydration. Because if you have a dry fragment, you can understand that once you are trying to put in the bonding agent, it won't percolate, it won't get deeper. And that's what we did in the second paper, which is about the confocal scanning electron microscopy. We did some work with the materials, and if you compare the present evidence for which material is the good one, we find it that there is no difference in any of the materials. When you are writing your answers and you are having a section about the materials to be used, the nano composites are as good as microhybrid composite as per this paper. And the standard of care is usually the flowable nanohybrid composites. So let's briefly talk about crown root fractures in next 2 to 3 minutes, and then we can have a question answers. So crown root fractures as an injury are a difficult injury than the crown fractures, because then you have tissues like cementum also involved, and things are intra-alveolar. So bottom line, and because this paper is a systematic review of case report, came from Kavitha Dental College, came from Meenakshi Ammal Dental College, and this paper talks about fragment reattachment as one of the methods. And if you look into how IADT guideline deals with it, the first thing it talks about is temporary stabilization of the fragment. So here also fragment reattachment is indicated. So if the patient comes to you, your first aim is to ensure that there is no pain. So if you are not able to stabilize the fragment, then the coronal fragment can be removed. And then in cases where there is uncomplicated crown root fractures, you can apply a glass ionomer cement or maybe calcium hydroxide, and then maybe there may be other treatment modalities. What are those treatment modalities? It can be extrusion. It can be about maybe a 360 degree, or 180 degree rotation. It can be about surgical extrusion. It can be orthodontic extrusion, root submergence in some cases. So these are the things which are there with you. Similarly, for the crown root fractures which are complicated or pulp is exposed, So in these cases, the emergency phase is always the fragment stabilization if it is possible. And then for immature root apex cases, always try to perform vital pulp therapy procedures, and just to ensure that there is some maturity which happens, and then you can do maybe a post and core, or you can perform other treatments which I mentioned before. So let's look at a couple of cases. So this child, a 10-year-old male, reported 2 hours after trauma, and you can see a fracture line going intra-alveolarly. So in my experience, because I've done a lot of cases with lasers, and I have tried to be little conservative in terms of flap, but down the line, I have seen that it's always better to get a flap, because once you have a flap, you have a complete control. Because it's not tough. You are not giving a releasing incision. You are just doing an envelope flap. So when we do that in our postgraduate program, it's quite easy. So just remove the fragment, and in this case, you can see how the fragment was cleaned. That's how it looks in all the segments. We performed the root canal treatment, and then we went ahead and we did the total etch, and then the fragment reattached. That's the immediate post-op for you. That's 3 months follow-up. Patient comes back, and then the fragment is off. It happens, and you need to see that if there is a delay, there will be some gingival growth. So we performed some gingivectomy procedure. This was a scalpel gingivectomy procedure, and then we went in. We placed a post. Use the same fragment. So you don't give up on your fragments. You always preserve your fragments, and then you can. This is the case summary, and then for the 3 months. And that's 3 months radiographic. Similar case with a laser being used. In this case, the flap was done, and then there was some gingival tissue which was covering because there was a delay. So what we did the exposures. Then we prepared the fragments and then placed in the post. And it's quite tricky once the post is inside and you're putting it as in the coronal portion on top. You need to ensure, you need to maybe do some iterations, but it works. And that's how we finished that case. So as we end, there is possibility of crown root fractures where the fragment reattachments can be there. This is one of our works. And here also the rehydration by humidification proved to be better. So the bottom, even if you are not doing humidification, that's fine. But then rehydration has to be one of your main stays when you're trying to work towards the success of crown root fractures, especially fragment reattachments. And as we end, the future is there for you because it's happening right in front of our eyes. When I started my dental traumatology way back in 2009 and 10 as a third year postgraduate student with my first paper, from then until now, things have changed drastically. Things have changed drastically in past 5 years, even in India. So when you look into how research is progressing, there are a lot of works in crown and crown root fractures in terms of research, which are there at the bench level. So you need some translations for that. You need trials, and then you need treatment paradigms, which are very useful to you, especially in any part of the world. So that's the beauty of management of crown and crown root fractures. And thank you very much. I will be very happy to answer any of your queries here or in any of the platforms. You can email me or you can ask for any of the papers or advice for your exams. Best wishes for a very good exams and best wishes for your life. Thank you so much.
Thank you, Dr. Nitesh. It was very informative.
Thank you.
Very, very, as usual, Dr. Nitesh and trauma goes synonymously.
Ji.
Very informative, and I am very sure that the PGs must have learned a lot from it. Faisal sir, there were questions, but Dr. Nitesh has already answered it.
Yeah, it's already been answered.
Yes.
So,
There are
just
no
a
new
couple of
questions,
questions, just a couple of questions which I said I will answer live. One of them asked about the periapical grading system. So in periapical grading system, generally the one which we use for IOPA is known as Ostrovic's classification. So Ostrovic's classification, you can search that, read it. It's very easy, just 5 classes, and that depends upon only 2 dimensions. And then the same thing if you are looking at for CBCT, always remember Estrella's classification, ESTRELLA, Estrella's classification. So these are the 2 classifications which are there. And I've been seeing that a lot of them are asking that which is the best classification to use for primary dentition. So in all injuries, the best classification is definitely Andreassen's classification because it doesn't concern whether it's a primary tooth or permanent tooth. You just be descriptive, and it's quite easy for you to learn. And even WHO is based on that. NA0D is based on that. One more question, which I said I will answer live. It was about the long-term effects of primary tooth injuries. I think Dr. Kavitha will be covering on it. But the question was that if injury is in a primary dentition and the tooth is not erupting at 8 years of age, so there is definitely a chance that there will be some sort of malformation which might have occurred on the permanent dentition. So that will all depend on what type of malformation it is. In case it's an odontome-like malformation, in case it is crown dilaceration or a radicular dilaceration. So those teeth are not to be moved orthodontically. So then the only option you have is extraction. However, there may be chance where you can pull the tooth down, and if it is just a just a retardation of eruption, that can be managed. I think just these questions were there.
Thank you. I think that
Thank you,
has been
Dr.
answered.
Nitish.
Thank you, sir.
Thank you, Dr. Nitish. It was a very informative lecture. I'm sure that its ongoing PGs and other PGs also would gain a lot from your lecture. Thank you very much, sir.
Thank you.
Thank you so much, sir. There are some more questions. I think sir will answer it live on the question and answer page itself.
I can type it. You can
I request
continue with the
Mr. Dev to display the certificate of appreciation to Dr. Nitesh Tewari, sir.
Thank you, sir. Thank you.
Thank you.
Thank you, sir. The next lecture would be on management of luxation injuries and avulsion by Dr. Sharan Sargod, sir. I would kindly request Dr. Gunjan Yadav, ma'am, to introduce the speaker, Dr. Sharan Sargod, sir.
Thank you, Dr. Viren. A very good afternoon to respected seniors, dear friends and dear PGs. It's my pleasure to introduce Dr. Sharan Sargod, sir. He is a professor, Department of Pediatric and Preventive Dentistry, Yenapaya University, and Director, Densho Dental Clinics Private. Dr. Sharan sir has earned his MDS degree from RGUHS in 2002. Since then, he is actively involved in teaching and research at Yenapaya Dental College, Mangalore. He was the former head of the Department of Pediatric and Preventive Dentistry, a practicing clinician with special interest in orofacial myotherapy, dental traumatology, and pulp therapy. He is the first recipient of the Young Periodontist Award by the ISPPD and has been guest speaker at various national conferences and meetings. It's my pleasure, sir, to invite you here. And sir will be speaking on management of luxation injuries and avulsion. Over to you, sir.
Thank you very much, madam.
Thank you, sir.
And good afternoon to all the esteemed panel members and Secretary Dr. Virendra Goyal. I think we can start sharing my presentation.
Thank you for joining us, sir. I would request Mr. Dev to display the presentation.
Hello, everyone. Welcome to this part of management of traumatic injuries to the teeth. I'll be covering management of luxation and avulsion injuries. I bring greetings from Yenapaya University, Mangalore. As we all are aware, tooth trauma has been and continues to be a common occurrence, which we all must be prepared to assess and treat when necessary. It has no predictable pattern, intensity, or extensiveness, and most often it happens when you're least prepared for it. Let's see some epidemiological trends.
Vasu, the screen is not
Luxation
visible.
injuries contributes to about 44.
Mr. Dev, please check. The
Yeah.
screen is not live.
Yeah, the video is not there.
Sir, your picture is coming, sir.
No, that's what I say. He needs to share the video. That's important. The video is not there, only the audio is there. Yeah, now we can
Now
see
it is
the
Luxation is about
Yes.
50%. Concussion
Start it,
is
Mr.
about
Dev.
19%. Luxation or lateral luxation
Vasudev, it should be from the very start of the presentation, not from in between. Now you start.
Hello everyone, welcome to this part of management of traumatic injuries to the teeth. I'll be covering management of luxation and avulsion injuries. I bring greetings from NFI University, Bangalore. As we all are aware, tooth trauma has been and continues to be a common occurrence, which we all must be prepared to assess and treat when necessary. It has no predictable pattern, intensity, or extensiveness, and most often it happens when you're least prepared for it. Let's see some epidemiological trends. Luxation injuries contributes to about 44%. In that, subluxation is about 50%, concussion is about 19%, luxation or lateral luxation is about 17%, inclusion is 6%, exclusion and avulsion is about 4%. What we need to understand here is in children, it's most common to find subluxation and concussion type of injuries, or more or less shaking type of injuries than breaking type of injuries. Let's see management of concussion and subluxation. In concussion, the tooth is hurt, but there is no severe tear or damage to the median. The tooth may be sensitive to biting and sensitive to touch, sometimes sensitive to heat and food. Whereas in subluxation, the tooth is not displaced, but may be slightly mobile, little more than the normal limits of the PDM. In both the cases, if the injury is not interfering with the occlusion or the biting pattern of the child, just soft diet and the tooth needs to be kept under observation. If it is interfering with the occlusion, or if the mobility is more than 2 mm, it is better to splint with a flexible splint for less than 7 to 10 days. Lateral luxation. Tooth is displaced facially, lingually, mesially, or distally, other than axially. If there is a displacement, we call it as lateral luxation. Now, the management here is to reposition it to its original site and splint it for a short period of time of 1 to 2 weeks. One important thing is, while repositioning, you cannot just push the tooth back to its socket. Many a times there will be resistance, or tooth may not get reduced to its original site. In these cases, slow digital pressure by pushing it a little downwards and then popping it or pushing it back to the exact socket direction is what is important to put the tooth in the original position. If you just try to move it from lingual side to facial side, there will be a lot of resistance because the tooth would have gone little upwards. So you need to have the force moved downwards and then upwards, as shown in the figure, to get it repositioned into its original position. This has to be done with slow digital manipulation of the bone along with the tooth. Exclusive luxation. The tooth is partially come out of the socket. In these cases, the tooth should be pushed back to its original position, but you will notice that the tooth will try to combine because of the clot in the socket or because of the pressure in the socket. So it is important to push the tooth back to its socket and hold it in that position for a few minutes till the pressure gets released, or you can roll a gauze piece and ask the patient to hold on to it before you splint it. Again, you splint it for a short period of 1 to 2 weeks to stabilize the tooth. Intrusion. The tooth is gone inside the socket. It is sort of a comminution type of fracture. It's one of the severe type of fractures. The intrusion could be minimal, or it could be severe intrusion where you cannot see the tooth at all. The management strategies depend on the amount of intrusion which has happened, the developmental status of the tooth, and the surrounding associated traumatic injuries along with intrusion. If the intrusion is less than 3 mm, you can just keep the tooth under observation and allow it to re-erode by itself. We refer that as passive repositioning. If the intrusion is between 3 to 7 mm, it is unpredictable, so advised orthodontic extrusion. If the intrusion is more than 7 mm, where you can see only the intruded tooth incisors, or many a times you may not be able to appreciate the incisor at all, in those cases, we recommend surgical exclusion. Or we call it as surgical repositioning, where the intruded tooth is held with the forceps and slowly teased out of the socket. You should not extract the tooth out of the socket completely like an avulsion. You have to tease the tooth into its original position by holding with an extraction forceps. Now here is a case where there is so much of intrusion that you cannot see the tooth at all. And as I said, it is a comminution type of fracture where the tooth is intruded almost into the nasal cavity. In this case, you need to reposition it. Here we didn't use the forceps, but rather I put my finger into the nasal cavity and pushed the tooth out and repositioned it into its original position. As I mentioned, if the tooth is immature, even if it is more than 7 mm in young children, you can wait for the tooth to reposition by itself by spontaneous repositioning. Even if the root is completed in the age group of 12 to 16 or 12 to 17, because the bone is soft, there are chances that the tooth might erode in case of up to 7 mm. If it is more than 7 mm, you should consider orthodontic extrusion or surgical repositioning. In above 17 years or 18 years, if it is more than 7 mm, it is better to directly go for surgical extrusion. What is important to understand here is when you wait and watch for spontaneous eruption to happen, the eruption is evident in about 3 to 4 weeks. If you notice no evidence of eruption in about 3 to 4 weeks, that means the tooth is tightly locked inside the bone, it would require orthodontic extrusion. majority of the intrusion cases, if the root is completed, there is definite chance of pulpal necrosis. So root canal treatment is indicated after the tooth is repositioned. Some of the additional update from IIDT 2020 guidelines, pulp sensitivity might be negative, and this can remain like that for several months. So endodontic treatment is never started based on negative sensitivity alone, and we may have to wait for about 3 months and then make a radiograph. If we notice any periapical changes only, we need to start root canal treatment. Otherwise, it could be kept under observation. Give it a chance for revascularization. If at all you notice any evidence inflammatory root resorption, during the follow-up, you can start root canal treatment immediately. After removal of the pulp tissue, you can place calcium hydroxide or triple antibiotic medicament for 4 to 6 weeks respectively. Next, coming to severe form of injury called as avulsion. Avulsion simply means exarticulation, that is, tooth is come out of the socket. But tooth is just come out of the socket, but the tooth is available. So, if you are following Ellis classification, please note that according to Ellis classification, exarticulation or avulsion comes under the class of 7 and not class 5. Because avulsion, according to Ellis, is coming under the category of displacement of the tooth, that is Ellis class 7, where the tooth has come out of the socket but available for implantation. Whereas tooth lost due to trauma is Ellis class 5, where tooth came out of the socket but it is not available, or tooth is just lost due to trauma. Because the management strategies for managing an avulsed tooth is different from a lost tooth, it is important to consider this as a separate entity because the management strategies differ. Please note, Ellis class 5 is tooth lost due to trauma and not avulsion. Let's see the management of avulsed permanent tooth. This management could be divided into 5 categories. First one be management at the site of the injury. If at all you are not able to manage it at the site of injury, you can use a suitable transport medium to transport it to the dental office. The patient can come to the dental office. What to do in the clinical setting? Adjunctive drug therapy consideration, and finally restoration of the avulsed tooth. Let's see one by one. Management at the site of injury. Replant it immediately if possible. Best prognosis if it is replanted within 15 minutes. Earlier recommendations said, if contaminated, rinse with tap water and replant it immediately. The present IIDT 2020 guidelines say, rinse it with saline or milk and replant it immediately. If at all not able to replant, place it in the best suitable transport medium available and transport it to the dental clinic. Now we all know there are n number of transport mediums. Hanks balance solution, wire span, Eagles medium, organ transportation medium. Then you have red mulberry, pomegranate, that juice, this juice, egg white, Gatorade, contact lens solution, propolis, you name it. There are a number of transport mediums, but all these are under research based on one or two articles. There is no concrete evidence to prove, or enough evidence as of 2020 to prove that one is better than the other. So IIDT currently recommends only 3 transport mediums: Hans balance salt solution being the best, milk, which is almost same or similar to Hans balance salt solution, patient saliva by spitting it onto the cup. Also, 2020 regulation recommends, if nothing is available, at least water. So you might get a question of critically evaluate various transport mediums available. You can mention all of them, but please quote IIDT article 2020 to substantiate the best available evidence on these 3 transport mediums. You may be asked about the composition of certain transport mediums like Hans balance salt solution, which you should know at least of Hans balance salt solution. What you need to also understand is not any milk, preferably tone milk or cold milk and not hot milk. Generally, from the site to the office, the avulsion tooth category can fall into 3 groups. Number 1, there could be a viable PDL, which simply means the tooth has been replanted immediately within 15 minutes at the site of the accident. Or there could be a group 2, where tooth has been kept in the storage medium, and before they put it in the storage medium, the total extraoral dry time was less than 60 minutes. It's important to understand how much duration was lapsed before the tooth was placed in a storage medium. Group 3, where PDL cells are unlikely to be viable, that means extraoral dry time was more than 60 minutes, regardless whether they placed it in storage medium or. So these are the main categories or clinical situations which you might encounter in your day-to-day practice. Let's see one by one. Managing a mature tooth with less than 1 hour of the dry time, where the tooth could have been replanted or it is placed in a suitable transport medium and got to the dental clinic. Here, our objective is to maintain the vitality of the PDL cells, because that is our aim. So during clinical examination, if HPSS is there, place it in that so that you don't further delay the time. Handle the tooth by the crown only and put it back to its socket or replant it and splint it. Remove the pulp in 7 to 14 days. You can place calcium hydroxide or antibiotic dressing for about 4 weeks. If it is antibiotic dressing with an intention to prevent resorption, then it could be placed up to 6 weeks. You can obturate the canal in 2 months. Suppose the tooth is being got in a transport medium, you follow the similar or same thing what I already mentioned. Management of the socket. Gently aspirate the clot which is formed in the socket. You can use saline forcefully to dislodge the clot, but do not curate the socket because we don't want to damage the severed PDL fibers on the socket side. Do not wet the socket. If alveolar bone is collapsed, you can just use blunt end of or reverse end of the mouth mirror to reflect and reposition it a little bit. But aggressive manipulation of the socket should never be done. Once the tooth is placed, the bone around the socket is compressed for close adaptation. Tightly suture the soft tissues, lacerated gingiva if it is there. If it is a clean, neat type of avulsion, even suturing is not required. Coming to splinting, I'm going to discuss splinting in general, both for avulsion and luxation injuries. There are many methods of splinting using orthodontic wires, orthodontic brackets, fiber reinforced splints, etc. But for management of traumatic injuries, it's simple and easy to use soft arch wire or multi-stranded arch wire, multi-stranded wires, which you get ready-made, or you can use ligature wires and make a multi-stranded wire. IIDT also recommends using fishing line 0.25 mm, and we have a wrong assumption that you keep the splint for long duration of time, stronger the tooth becomes or healing will be better. But we have understood that splinting should be of short duration for 10 to 14 days, and only in case of associated fractures like alveolar fractures, root fractures, only extended time or longer duration is required. Never do figure of 8 or circumferential wiring for managing traumatic injuries, especially the injuries to the PDN fibers. You can see the kind of wiring which was done in this particular case. It's messy. It's not stable enough. These circumferential wirings will cause persistent gingival inflammation, which is one of the reasons for infection-related root resorption or replacement root resorption. So never do kind of a splinting which will cause inflammation to the gingiva around the tooth which has been replanted or repositioned. One of the best methods recommended by Anderson is titanium trauma splint, which is supposed to be flexible enough, yet sturdy. It has diamond-shaped gaps in which composite could be placed, but it is expensive though. If you see the IADT 2020 recommendation for splinting, you notice that subluxation, extrusive luxation, lateral luxation in certain cases, all are less than 2 weeks of splinting. It is only for severe intrusion, root fractures, you splint it for 4 weeks. If root fracture is at the cervical 1/3, then it is 4 months. In avulsion cases, where we intend the PDN to regenerate, the splinting should be of short duration, less than 2 weeks. In a situation where we don't intend the PDN healing to happen, like in cases of extended extraoral dry time of more than 60 minutes, you can splint it up to 4 weeks until the tooth has become stable. If the displacement or luxation injuries are associated with alveolar fractures only, that it is recommended up to 4 weeks. Most importantly, it should always be a flexible splint and not a semi-rigid or rigid splint. In old recommendation for splinting home care, they recommended to use soft diet and no biting on the splinted tooth. In the current update, IIDT update, and what we have learned from literature from orthopedics, where implant surgeries or fracture surgeries, the patient is made to walk on the same day or the next day itself. Because we have understood from them that it is important for regeneration to happen, there should be some amount of physiological mobility. So in the present recommendation, if splint is there, it is not required for the patient to maintain a liquid diet or soft diet. Patient can have regular diet. However, avoid biting directly on anything hard on the splinted teeth. What is important is maintenance of a very good oral hygiene. As I mentioned earlier, persistent gingival inflammation is one of the main reasons for inflammatory root resorption or infection-related root resorption. Therefore, teaching oral hygiene methods to the patient with oral hygiene aids, chlorhexidine mouthwash, gels is very, very important. Systemic antibiotics is recommended for avulsion tooth, as the tooth will be always contaminated. In subluxation, luxation type of injuries, where there is no tearing of the gingivas or associated injuries, there is no need of antibiotics. Tetanus consultation is required and analgesics. Next, managing an avulsed immature tooth with open apex with less than 1 hour of dry time. Our main objective here is to revitalize the severed pulp tissue. As the tooth is immature, there is high chances of revascularization or reconnection happening from the apical end. It has best chance if it is replanted within 15 minutes, not later than 60 minutes. You can replant it and splint it for 2 weeks. And periodically make radiographs to check the root growth or for development of any periapical pathology. If there is notice of resorption or periapical pathology, then apexification or revitalization, revascularization procedures could be attempted. Next category is managing a mature tooth with closed apex with more than 1 hour of extraoral dry time. Here, we know that the median regeneration is impossible. So our objective here is to delay the inevitable root resorption. So what we can do, remove only loose debris and visible contamination, put it back to socket and splint it for 2 weeks. Start endo within 2 weeks. If you delay starting the endo, the dead and dying part tissue inside the canal can stimulate or form an inflammatory cascade, which could be detrimental for healing process or which can encourage infection-related inflammation or inflammatory root resorption at the roots. So it's important to remove the pulp tissue within 7 to 14 days. Place calcium hydroxide dressing for about 4 weeks. If you're placing antibiotic or corticosteroid dressing with an intention to stop or halt the resorption process in extended extraoral dry time cases, it can be kept for 6 weeks. And always anticipate some kind of replacement resorption in the future. This should be communicated and informed to the patient in advance. What is no longer recommended according to IIDT 2020 regulation is removal of PDL fragments or fibers. Earlier, they recommended that you have to scrape and remove all the PDL fibers to prevent resorption by using sodium hypochlorite, citric acid, sometimes scalar. All this is no more recommended according to IIDT 2020 guidelines. Extraoral endodontics, or you replant it, the outcome is same. So no more recommended to do extraoral endodontics. You soak it in doxycycline for immature growth. You soak it in fluoride, 2% fluoride. All this is no more recommended because it lacks evidence. In 2012, there was a recommendation of using amidogaine, supposed to regenerate PDN fibers, even because of lack of evidence that does not appear in the 2020 IIDT guidelines. So please do not write in your answers regarding extraoral endodontics, removal of the fragments using citric acid, sodium hypochlorite, soaking it in antibiotics, corticosteroids, all this, please do not mention in your answers and please quote it as 2020 regulation. Next, coming to managing adverse immature growth with more than 1 hour extraoral diet time. The old regulation said such tooth does not have any scope, of course, depending on the amount of root completion, and it was advised not to replant. But according to 2020 regulation, they still tell us to replant and splint it. Avoid RCP unless there is clinical and radiographic evidence of any infection or resorption. Give it a chance for revascularization to happen. If it is not happening, you can go for apexification or bulk revascularization procedures. The prognosis is not so good. So, and the inflammatory root resorption is very high in children because of increase in bone or cellular turnover rate in children. Therefore, the risk of root resorption is very high in children. So inform the patient about the need for decoronation or extraction in the future. And all this is dependent on the amount of root completion which is still pending. Some additional considerations. We must understand that even though initially the tooth might stabilize and still look good, all levels permanently require a follow-up of at least up to 5 years to monitor tooth regularly. There is a follow-up schedule recommended by IIDT in their guidelines. I would urge all of you all to refer that document of IIDT 2020 guidelines on the follow-up visit recommendation for each trauma category. The potential complications include inflammatory root resorption. Majority of the time it is infection related. Please do not follow open dressing method. That is, you slit the tooth, don't remove the pulp. When patient develops pain, you just remove the pulp tissue and keep the tooth open. There can be contamination from oral end to the peripheral end. So, infection-related resorption is very common if persistent gingival inflammation is there or root canal contamination is there. So, it's important to take care of all these things to delay the inevitable root resorption. In young children or growing children, one of the potential complications is submergence of the tooth. There are different methods of managing submergence. It is beyond scope of today's lecture, but you can have other complications associated with a replanted tooth, which needs to be communicated with the patient and could be managed accordingly in the future, because adverse tooth may have an initial objective and long-term objectives. Some of the helpful considerations according to IIDT 2020 regulation. What if the tooth is wrongly repositioned by a healthcare worker or anybody? We still have scope to reposition it within 48 hours. Support left to right, right to left, or lingual to buccal, still okay as long as it is put back in the socket, but it can be repositioned within 48 hours. As I mentioned, if there is visible contamination of the root, it is recommended to agitate with storage medium, milk, or stream of saline. During replantation, IIDT 2020 regulation recommend us to use local anesthesia without vasoconstrictor, though not sufficient evidence is there, but still it appears in the regulation. It is preferable to use, not mandatory. This will prevent from restricting the transient blood supply to the periapical area. The same recommendation is also given in case of revascularization or regeneration procedures. There are two new terminologies which, according to 2020 guidelines, you all must know. Inflammatory root resorption is currently referred as infection-related root resorption. Replacement root resorption now is known as ankylosis-related root resorption. Okay, where the dentin cementum is replaced by bone. You may get a question on the comparison between 2012 guidelines, IIDT guidelines versus 2020 IIDT guidelines. Most of the things I've already mentioned through my presentation. Just to highlight few, in 2020 guidelines, we need to rinse it with milk, saline, or patient saliva itself. Earlier guidelines said that you can carry the tooth to the dental clinic inside the patient mouth, on the buccal vestibule, or under the tongue, which is no more recommended in 2020 guidelines. You need to spit the saliva in a cup, place the tooth in that, and carry it to the dentist. Remaining, I'm sure it is visible in the slide. Most of it is I've discussed through my presentation. Surface treatment, unnecessary surface treatment, soaking in antibiotics, washing in fluoride, all this is no more recommended in 2020 guidelines. It simply delays the extraoral dry time or extraoral time further. And these are all based on empirical and more or less like lab studies than actual clinical trials. So as of now, or as of 2020, there are not much evidence supporting this. Therefore, it doesn't appear in 2020 guidelines. Corticosteroid calcium hydroxide dressing. Calcium hydroxide dressing 2 weeks to 4 weeks, whereas if you're putting antibiotic dressing to control infection and control the resorption process, it should be kept for minimum of 6 weeks. Splinting material diameter, they are just told flexible splint or semi-rigid splint in 2012 guidelines. According to 2020 guidelines, it should be passive flexible splint, 0.6 wire or 0.4 stainless steel wire or multi-standard wire. You can use nylon fishing line reinforced with flowable composite. About the splinting duration we have discussed. About tooth put in wrong socket or interchange we discussed already. About antibiotic, tetracycline, amoxicillin, penicillin in 2012. Here amoxicillin, penicillin and doxycycline is not recommended for patients under 12 years of age. Last, coming to the conclusion. The mechanism of spontaneous eruption in an intruded tooth is not known, because none of the theories of eruption will hold good in these cases. We simply don't know how the tooth comes back to its original position. Which theory of eruption holds good here? Next, it's important to comply with an acceptable dental trauma guidelines, be it IIDT. We generally follow IIDT or ISPPD, sorry, AAPD has adopted the IIDT guidelines, or you can follow European or Royal College of Surgeons of England, any guidelines. What is important is when you comply with any of these guidelines, the outcome will be better. We must also understand, though for academic purpose, for discussion purpose, we have divided these topics into different categories of tooth injuries, periodontal injuries, primary teeth injuries. We must understand that injuries do not always fall into one group or category. It often comes together or in combinations. So the treatment outcome, the treatment approaches varies depending on the type of injuries or combination of injuries which it is associated with. It's important to have a long-term follow-up for all type of dental injuries because many a times we cannot predict the outcomes of dental trauma. Some of the important questions I've put it on the slide by Yanapay University, Rajiv Gandhi University, D.Y. Patil University, Bharati Vidyapeeth University. I've combined all these questions. So you must understand that any of the category of luxation injuries might come as a separate question, especially intrusion injuries, or management of an avulse primary tooth or permanent tooth. Some of the helpful reference. IIDT has a special issue. I want all of you all to read the IIDT 2020 guidelines, which has been adapted by AAPD 2024 manual. You can also refer the dentaltraumaguide.org. Thank you very much and wish you all the very best for your upcoming exams. Thank you one and all.
Thank you, sir. Thank you so much. That was very knowledgeable session, sir. And I'm sure the PGs must have learned a lot and they can write very nicely in their exams if the question comes on this topic. Thank you, sir. Thank you again. Sir, there are many questions. Should we take up this time only, sir?
Dr. Gunjan, what we can do is we can request Dr. Sharath to type the answers and not into the Q&A, preferably into the chat so that everyone can read the answers. And then I request Dr. Sharath to share certain articles which could be of benefit to the students, like the articles related to your subject, like your topic, revascularization and all that. Whatever like best topic, articles you think, you can attach it into the chat box, right? And like you just need to select everyone and then select the file and then you can add up the articles there. Or if it is not possible for you, you can share it with me. Then I'll update all the articles into the chat box. This is a request.
Sure.
And in the meantime, we will start the next lecture. But if you have time, you are free for some time, you can just add up the answers in the chat box for the questions, few of the important questions which you feel are there.
Okay. Most of the things which I've mentioned is available on the 2020 guidelines of IIDT. The few of the questions I've already answered in the Q&A section. But there is one question I think it needs some explanation because that's the controversial statement which I have made. That is regarding the classification of LEs
where does the avulsion tooth fall into category, whether it is category 5 or category 7. I am referring from the original textbook of Ellis, and I got this reference from Ellis' original textbook from Government Dental College, Trivandrum. I'm not sure how many colleges have this textbook. I think it's only 2 textbooks are available in India. One is in Nair Dental College and one is in GDC Trivandrum. If anybody can get a copy of it, it says that Ellis, according to Ellis' original, Ellis, avulsion tooth means what? It is displaced away from its original position. That is something like scapula avulsion and or patella avulsion. Like that, avulsion means the tooth is exarticulated. So that comes under the category of displacement of the tooth, which is Ellis class 7, where the tooth could be displaced inside, outside, partially outside, labially or lingually. So all these categories are put together under Ellis class 7 of displacement type of injury. Therefore, avulsion comes under that category. Whereas Ellis describes 5 as tooth lost due to trauma. Now, how different it is? Some say, so what? It has still come out of the socket. But the management strategy for an avulsion tooth is different, and a tooth which is lost due to trauma is different. Therefore, it should be considered as a separate entity. Unfortunately, many textbooks have re-quoted it without referring this original textbook of Ellis by saying avulsion and tooth loss due to trauma are put under the category of Ellis 5, but that is not correct. It is just for academic interest that I mentioned this, and it makes sense when you refer it as an original document. I hope it is clear. Remaining questions, I'll type and answer it in the Q&A section. Faisal sir, any inputs from your side?
Thank you very much, sir, for your nice lecture, very informative. So I think it was modified in 1980s by Hargreaves or somebody, and they have included this 5 as avulsion. The original Ellis classification was modified later. That's what we are learning and teaching now. That's what I think. I'm not very sure about the year in which it was modified.
Sir, even in that document, it is still coming as tooth loss due to trauma.
Is it?
Yes, sir.
And there is scope for more discussion in this.
Yes. Yeah. So it's a small thing, but because it's from Ellis' original textbook, I'm making this tip.
Okay. Thank you very much, Dr. Sharan, for a very informative lecture. PGs will gain a lot of knowledge out of your lecture. Thank you very much.
Thank you, sir. Thank you, sir.
Thank you so much, sir. That was a very good presentation. I think sir will be answering all the questions in the question and answer box. The students can please note it. I would like to request Mr. Dev to display the certificate of appreciation to Sharan Sargod, sir. The next presentation would be traumatic dental injuries in primary dentition by Dr. Kavitha Kumar. I request Dr. Faisal sir to introduce Dr. Kavitha Kumar to the audience.
Hello, good afternoon and welcome Dr. Kavitha. A short introduction for Dr. Kavitha Kumar. He's a practicing dentist at Innocent Smiles Dental Clinic in Kerala, Ernakulam. And she's a very popular person in ISPPD. She has done the role of quizmaster at various ISPPD national conferences. And she's also a postgraduate trainer at state and national level programs, and presently the Secretary of Association of Pediatric and Preventive Dentists of Kerala. Welcome, Dr. Kavitha, for your lecture.
Thank you so much, sir. I request Mr. Dev to display the presentation.
Welcome to the 6th Rapid Review, virtual PediaRare Rapid Review organized by the ISPPD. I am Dr. Kavitha Kumar, and I will be talking on the topic traumatic dental injuries in primary dentition. Injuries to children are a major threat to their health, and they are generally neglected public health problem. For children aged 0 to 6 years, oral injuries account for 18% of all physical injuries, and mouth is the second most common area of the body to be injured. A recent meta-analysis on traumatic dental injuries reveals a world prevalence of 22.7%. Repeated TDIs are also frequently seen in children. Literature regarding TDI in primary teeth has reported 1/3 of preschool children have had some form of dental trauma. And the prevalence of TDI in preschool children in different countries by El Karmi et al. In 2015 ranges from 6.2% to 41.6%. The gender variations in traumatic injuries exist from an early age and are consistent throughout childhood and adolescence. Boys usually encounter more injuries than girls. Now, everything will be discussed based on the IADT 2020 guidelines. I'll be talking about the management of each of the injuries as well as what is different in this guideline from the earlier guideline. Now, initially, there'll be an initial presentation of the patient. So the first step, according to the IADT 2020 guidelines, is to minimize anxiety to the child and parent. And this point has been stressed enough in the guideline. Knee-to-knee examination can be helpful in examining a young child. The literature shows that the use of a structured history at the initial consultation leads to a significant improvement in the quality of the trauma. There are a variety of structured histories available in current textbooks or used at different specialist centers. Going to the initial assessment and documentation, we need to assess the medical status, tetanus status, safeguarding various considerations, take a good history of the time since injury, the mechanism of injury, the initial bleeding, pain, or presence of any tooth fragments, then go ahead and do a clinical examination for mobility, displacement, occlusion, and soft tissue lacerations. Radiographs are indicated only when they change the management to minimize exposure, especially for toddlers. Appropriate to the age pain control should be done, and parental instructions should be given to the parent. What are these instructions? Successful healing obviously depends on good oral hygiene, so the parents and caregivers, they are advised regarding the care of injured teeth and prevention of further injury. They are advised on how to clean the area with a soft brush or a cotton swab, to use the alcohol-free chlorhexidine gluconate 0.12% mouth rinse. Care to be taken while eating not to further traumatize the injured tooth. And though children may not be complaining of pain, parents should be watchful about signs of infection. Now, among the consequences of TDI, psychological trauma with pain and disfigurement are the direct or immediate effects. And once this initial phase is over, there might be secondary effects like pulp necrosis, abscesses, discoloration, pulp obliteration, or tooth loss. Now, entire diagnosis and treatment planning, as I said, is based on the IADT 2020 guideline. The first and foremost is enamel fractures, where the fracture involves only the enamel. So here we just smoothen the sharp edges. No splinting is done. or we consider a small composite restoration for comfort and aesthetics. Follow-up clinically at 6 to 8 weeks and radiographs are not routinely indicated. The next is the enamel dentin fracture with no pulpal exposure. Here we cover all the exposed dentin with glass ionomer or composite, and the lost tooth structure can be restored using composite immediately or at a later appointment. In this case, however, a baseline radiograph is indicated. The outcomes here could be favorable or unfavorable. A favorable outcome is when the tooth is asymptomatic, whereas an unfavorable outcome is when the tooth becomes symptomatic, shows any kind of discolorations, pulp necrosis, or no further root development in an immature tooth. Moving ahead to complicated crown fractures, that is where the pulp is exposed. Again, a radiograph is recommended with size 0 film or an occlusal with size 2 film. Here the treatment is based on partial or total pulpotomy, but many times what the guidelines say is no treatment can be done. That means it doesn't mean that no treatment is done. It means that the center where the child is seen, if it is a center which cannot handle children, then they have the provision to refer it appropriately. And that is why no treatment should be done is what is said. But the treatment per se is partial or total pulpotomy. We go in for clinical examinations every week, 6 to 8 weeks, and not every week, first week, 6 to 8 weeks, and then 1 year. Now here also the outcomes could be similar, that is they could be favorable or unfavorable. Now, moving ahead to crown root fractures, if the coronal fragment is not displaced, then no treatment is required. If the coronal fragment is displaced, but it is not excessively mobile, we can leave the coronal fragment to spontaneously reposition, even if there is some occlusal interference. If the coronal fragment is displaced and mobile, extract only the loose coronal fragment is one option. The apical fragment should be left in place to be resorbed. Or we have another option, gently reposition the loose coronal fragment. If the fragment is unstable in its new position, stabilize the fragment with a flexible splint attached to the adjacent uninjured tooth. And we leave the splint in space for 4 weeks. Again here, we could have favorable outcomes wherein the tooth is asymptomatic, undergoes pulpal healing, and there is realignment of root and coronal fragment. Whereas in an unfavorable outcome, the tooth could become symptomatic, there could be crown discoloration, pulp necrosis, no further root development, and no improvement in the position of the tooth. Moving ahead to alveolar fracture, what we do here is we see that fracture involves the alveolar bone, labial, palatal, lingual, and may extend to the adjacent bone also. Mobility and discoloration of the segment with several teeth moving together are common findings. Occlusal interference is usually present. So what has to be done is these mobile teeth have to be repositioned, and the displaced segment also is repositioned and stabilized for 4 weeks. We do a clinical examination after 1 week, 4 weeks for splint removal, 8 weeks and 1 year. A follow-up in these cases is also indicated at the age of 6 years to monitor the eruption of the permanent teeth. The radiographic follow-up is done at 4 weeks and 1 year to assess the impact of the primary tooth and the permanent tooth germs in line of the alveolar fracture. And this radiograph may indicate the need for a more frequent follow-up whenever case to case. Now, other radiographs are indicated only when clinical findings are suggestive of pathosis. Okay, and the parents should always be informed to be watchful for any development of unfavorable symptoms. That is, this tooth could remain asymptomatic with realignment of the alveolar segment and no disturbance in the development of the permanent successor, or it could become symptomatic with signs of pulpal necrosis, no further root development in immature tooth, limited or no improvement in the position of the displaced segment, and a negative impact on the eruption of the permanent successor. Now moving ahead to periodontal injuries. The first one is concussion. Here the tooth is tender to touch, but has not been displaced, and there is no sulcular bleeding. No baseline radiograph is indicated here. We do just a follow-up at the first week and then 6 to 8 weeks. The radiographic follow-up is done only when indicated. Again, no treatment is needed. However, the outcome could be favorable or unfavorable, that is, the tooth could become symptomatic. The next injury is subluxation, where the tooth is tender to touch as it has increased mobility, but it is not displaced and there is mild sulcular bleeding. Here, a baseline radiograph is indicated and a clinical examination is only follow-up. No treatments again are usually done. Again, outcomes here also could be similarly favorable or unfavorable. When there is an extrusive luxation, what happens is there is partial displacement of the tooth out of its socket. So the tooth appears to be elongated. It could be excessively mobile. So the treatment decision is based on the degree of displacement, the mobility, the interference with occlusion, root formation, and the ability of the child to tolerate the emergency situation. Now, if this luxated tooth is not interfering with occlusion, we don't extract it and wait for spontaneous repositioning. However, if it is excessively mobile or extruded more than 3 mm, then we are advised to extract under local anesthesia. Similar outcomes here also could be asymptomatic with no interference in occlusion, or it could become symptomatic. Now, when it comes to lateral luxation, the tooth is displaced in the palatal or labial direction and the tooth will be immobile here. Occlusal interference may be present. What we do is, if there is minimal or no occlusal interference, then the tooth should be allowed to spontaneously reposition itself. And spontaneous repositioning will occur within 6 months. In situations of severe displacement, we have 2 options. Option A is extraction when there is a risk of ingestion or aspiration of the tooth. And option B is gentle repositioning and splinting in the new position for about 4 weeks. Here we do a follow-up for clinical examination at 1 week, 6 to 8 weeks, 6 months and 1 year. And if repositioned and splinted, we need to review after 1 week, 4 weeks for splint removal, 8 weeks, 6 months and 1 year. Where there are concerns that an unfavorable outcome is likely, then we need more follow-up. Again, here also, the luxated tooth could be symptomatic or asymptomatic. An asymptomatic tooth will get realigned and the occlusion will become normal, whereas a symptomatic tooth along with other symptoms could get ankylosed also. So ankylosis is one of the sequelae of this injury. Now, when you go ahead with intrusive luxation, here a radiograph is recommended. Now, when the apex is displaced through or towards the labial bone plate, the apical tip can be seen and the image of the tooth will appear foreshortened. Whereas when the apex is displaced towards the permanent tooth germ, the apical tooth cannot be visualized and the image of the tooth will appear elongated. Now, this tooth should be allowed to spontaneously reposition itself irrespective of the direction of displacement. Spontaneous improvement in the position of the intruded tooth will usually occur within 6 months. Some cases it may take up to 1 year. Again, a similar clinical exam follow-up is indicated for intrusion injuries also, where again it could become a favorable outcome if there is re-eruption of the intruded tooth and an unfavorable outcome if there is ankylosis of the intruded tooth. The last injury for a primary dental trauma is avulsion, where the tooth is completely out of the socket. What we should concentrate here is the location of the missing tooth should be explored during the trauma history and examination, especially if the accident was not witnessed by an adult. While avulsed teeth are most common out of the mouth, there is a risk that they can be embedded in any of the soft tissues, so that should be checked thoroughly. And if the avulsed tooth is not found, the child should be referred to for medical evaluation to an emergency room, especially when there are respiratory symptoms. The IADT 2020 guidelines does not recommend avulsed tooth to be replanted. But There are some controversial exceptions where people have replanted avulsed teeth, and there are studies which have followed up these replanted teeth. So a systematic review by Malmgren in 2013 followed up 41 replanted cases where some cases were without adverse outcomes. Holland in 2013 suggested aesthetic functional benefits and proposed root resection before replantation. Philippi et al. In 1997 gave a case report of successful replantation with root resection and calcium hydroxide obturation. But what are the important observations? Evidence is limited to case reports. No controlled studies or long-term outcomes are present. There is always a risk of pulp necrosis, ankylosis, root resorption, or permanent successor damage. And this is not recommended by IADT 2020, AAPD, or British Society of Pediatric Dentistry, and it should be considered only in exceptional, highly controlled circumstances. Now, just a gist, I'm going to give a chair-side algorithm of management of primary traumatic dental injuries according to the IADT guidelines. There you can divide the injuries into fractures and luxation, avulsion, or periodontal injuries. In fractures, when we have an enamel dentin fracture or an enamel fracture, we smooth it, restore it, and observe. Where you have pulpal exposure, you do a partial pulpotomy as the first line, and then only consider pulpotomy or pulpectomy. And when we have crown root fractures, we remove the mobile fragments and splint only if needed. When you have the periodontal injuries, you have concussion subluxation, which only need observation. Extrusive luxation, we can reposition if minor and extract if it is major or severe. Intrusion allows spontaneous re-eruption for all intrusion injuries, and do not replant avulsed primary teeth. So this is just like a gist of entirely what I spoke for this much time. Now, there's again a very beautiful article in Dental Traumatology wherein they have done a critical appraisal of these 2020 guidelines. And what is the most important highlight of this 2020 guidelines? The most important highlight according to this article is the the importance of reducing additional suffering and anxiety for the child, which has been very well taken into concern in this guideline. There is recommendation to reduce the child's exposure to radiation. 2012 guidelines suggest several diagnostic X-rays at various angles, whereas the 2020 guidelines will suggest radiographs only if it is absolutely essential. The 2012 guidelines recommended radiographs at follow-ups also, whereas 2020 guidelines does not specifically recommend radiographic follow-up. Now, the previous guidelines recommended the extraction of traumatically intruded or laterally luxated primary tooth if radiographic signs indicated its root apex was displaced into the developing permanent tooth germ. However, the current guidelines say that these intruded teeth will spontaneously reposition themselves irrespective of the direction of displacement. While luxation injuries in primary teeth result in deleterious sequelae in the permanent incisor, there is limited evidence to suggest that their immediate extraction will minimize damage to the permanent tooth germ. And in fact, there is a concern that the damage may be inflicted during the extraction per se. So this is the article by Nebu Philip, Hani Nazal, and Mandeep Singh Dugal, who have critically appraised the 2020 IADT guidelines, and I have only taken out the appraisal of the primary tooth dental trauma. So you can read it for critical appraisal of other trauma. Now going on to the sequelae of trauma to primary teeth on the development of permanent teeth, we have hard tissue defects, which are enamel discolorations, opacity, hypoplasia, enamel surface defects. We have morphological malformations like crown root dilacerations, odontoma-like malformations, partial or complete root arrest, and we have eruption disturbances like ectopic eruption, impaction, early or late eruption, sequestration of the tooth germ itself in severe cases. Now, Anderson et al. Conducted one of the first studies that described the long-term sequelae of injury to primary teeth on the permanent teeth. They highlighted that the most common site of primary tooth trauma is the maxillary anterior region, and the most common type is luxation. So what is the biological basis of this sequelae? The biological basis is three factors: injury, energy, and direction. Okay, it detects the extent of damage. Pulpal and periodontal healing balance determines necrosis versus calcification versus resorption, and close anatomic relation to the successors. That is, the bone is thin, less than 3 mm between the primary incisor apex and the permanent tooth bud, which makes it highly vulnerable. And this was demonstrated by Puglisi et al. In 2020. These sequelae could be immediate or delayed. Immediate, which is within hours or weeks, which is concussion, subluxation, mobility, discoloration, gingival bleeding, and delayed, whether is pulp necrosis, pulp canal obliteration, internal or external resorption, ankylosis, sinus tract formations, and periapical radiolucency. Now, going on to post-traumatic color change, which is one of the sequelae of trauma to primary teeth. There are three typical presentations: yellow discoloration, gray or dark discoloration, and a pink hue. Yellow discoloration suggests calcific metamorphosis. It's also called PCO or pulp canal obliteration, which is often asymptomatic. Gray or dark discoloration is associated with higher risk of pulpal necrosis, and a pink hue suggests internal resorption or pulpal hemorrhage. Now, a longitudinal study by Gortens et al. In 2020 said that darker crowns had higher risk of pulpal necrosis and infection, and monitor color change to teeth clinically and intervene only if they are symptomatic. Now, moving ahead to the epidemiology of PCO, the prevalence of PCO after primary TDI is 22 to 28%. It is more frequent after lateral luxation or extrusion and associated with younger age of injury. However, PCO alone is not any indication for endodontic treatment. PCO is nothing but yellow discoloration due to narrow canals where the tooth is asymptomatic and the PDL is normal. You only observe and intervene if pulp necrosis develop, because endodontic access may be challenging. So you need to avoid any kind of iatrogenic risk. Now, the next sequelae is pulpal necrosis, which is the most frequent serious complication across TDIs, presenting with pain, swelling, and sinus tract. Now, in primary teeth, when they develop pulpal necrosis, IATT 2020 advises extraction if signs of infection or risk to the successor, and pulpectomy in selected cases with restorable crowns. Again, antibiotics are not routinely indicated, but they are based on systemic signs like cellulitis. Root resorption is another sequelae where there could be external inflammatory resorption, internal resorption, or replacement resorption or ankylosis. Inflammatory resorption requires removal of the infection source, that is extraction often preferred, whereas ankylosis is intraocclusion and you need to monitor the occlusal development. There could be periodontal or alveolar sequelae like loss of attachment, marginal bone loss, gingival recession or fistula, soft tissue scars, and alveolar fracture healing may alter the eruption trajectory of the successors. Intrusion injuries inside the intrusion towards the tooth germ strongly predicts successor damage. Undiagnosed, untreated intrusion linked to severe long-term sequelae, and this needs follow-up until the permanent tooth eruption. Now, what is the long-term sequelae on permanent teeth? On permanent teeth, we have yellow or white enamel discoloration, white or yellow-brown discoloration, horizontal enamel hypoplasia, crown dilacerations, root duplication, vestibular root angulation, lateral root angulations or dilacerations, partial or complete arrest of root formation, sequestration of the entire tooth germ, and odontome-like malformations. Now, enamel discoloration or hypoplasia is the most frequently found sequelae on permanent incisors. Crown root dilacerations are also seen, and disturbances of eruption are also present. This is according to Cairo Vilasini at 2022. So obviously there is greater risk with intrusion and avulsion when these injuries occur less than 4 years of age. The severity depends on the stage of the bud development, and there is a recommended follow-up till the eruption of the permanent teeth. Now, there is again an interesting review by Nitesh Tewari sir in 2018, where following conclusions have been drawn. The age of the TDI affects the long-term sequelae of permanent teeth, with severity decreasing with age. The type of primary tooth TDI affects the long-term sequelae of permanent teeth, with avulsion being associated with the highest number. Crown root fracture in primary teeth can also cause long-term sequelae in permanent teeth as enamel discolorations or hypoplasia. Now, there is an interplay between various variables such as the age of the primary tooth TDI and the type of the primary tooth TDI, where the type is the stronger determinant of the severity than the age. Now, the long-term sequelae can affect adjacent teeth also and cause changes such as impaction of the teeth, ectopic teeth, crowding, abscess formation, impaction of the tooth with crowding, right? That is both together. Now, the mean age of reporting of LSP was dependent basically on associated fractures, and yellow or white enamel discoloration is the feature that we see when the trauma occurs in the earliest of ages. So this was the article which throws light on the long-term effects of traumatic dental injuries of primary dentition on permanent successors. It is a retrospective study of 596 teeth. Now, going ahead to the most important questions you could put on this topic that could be asked would be a critical evaluation on the recommendations of avulsed primary teeth. You can be asked about the recent concepts in the management of dental traumatic injuries in primary dentition. You could be asked on the sequelae of intrusive luxation in primary teeth, and you could be asked on traumatic injuries in primary teeth, and also a note on prevention. So wish you the very best of luck, and I hope all of you do well and benefit from this class here today. Thank you.
Thank you, ma'am, for such an informative lecture. Thank you so much. Sir, ma'am is already answering the questions. Sir, am I audible?
Yes,
Yeah.
you're audible.
Audible.
Thanking again Dr. Kavitha ma'am for such an informative lecture. So, sir, ma'am is already answering the questions on the chat box. So do we need to take up those?
No need actually.
Some of them were for the earlier speakers, so I didn't answer.
There is one question, ma'am.
Yeah.
Mouth guards for prevention of trauma in primary dentition, can they be used?
Can be used, but they are not recommended by any guidelines. So it's not evidence-based. That's it.
Okay, thank you. Thank you, ma'am. Thank you for such a wonderful presentation.
Thank you,
I would
Dr.
request
Kavitha.
Mr. Dev to present the certificate of appreciation to Dr. Kavitha Kumar.
Thank you.
Thank you, Dr. Kavitha.
Thank you, sir.
Thanks everyone for joining. That's all for the day 3. We'll be joining again for the last day tomorrow at around 9:15. Please log in 15 minutes early. See everyone tomorrow. Have a nice day. Thank you.
Thank you, Faisal, sir.
Thank you, Dr. Madhu. Thank you.
Thank you, Sharan.
Thank you, sir.
Bye, Dr. Gunjan.
Bye, Dr. Gunjan. Bye, sir.
Thank you, sir. Thank
Well,
you.
sir.
Bye, Dr. Bye. Thank you.
Thank you. Thank you, Dr.
I would
Vyas.
request Mr. Dev to present the certificate of appreciation to the moderators for the session. Dr. Faisal, sir. Thank you so much, sir, for joining us.
Thank you. Thank you, sir.
And the certificate of appreciation to Dr. Gunjan Yadav, ma'am. Thank you for joining us, ma'am.
Thank you. Thank you so much. Thank you, ISPPD and Madhu, sir, and team. Thank you so much, sir.
Thank you, ma'am. So you'll be joining tomorrow at
And good
9:15
evening.
a.m.
Yes.
Thank you, Goel, sir. Bye. Thank you, Madhu. Dr.
Thank
Madhu.
you, sir. Tomorrow we'll have tomorrow
Thank you,
session.
sir. Thank you, sir.
Thank you.
Yes. Bye, sir. Thank
Bye-bye.
you.